Okay, I think we're going to go ahead and get started. If everyone can come in and take their seats. I think there's still a few people walking over from the River campus that will straggle in, but why don't we go ahead and get started? I hope you've enjoyed the program so far today. I heard it was a good session over in the River campus with our mayor talking about democracy, I guess, and whether democracy is going to survive. So I wish I got to go over and go to that, but I heard it was really good. I want to welcome you to the School of Medicine and Dentistry George Engel Memorial Lecture. We heard Dr. Engel's name many times today and yesterday. And the George Engel Memorial Lecture was established by the School of Medicine and Dentistry alumni to continue the legacy of Dr. Engel. The theme of the lecture, as you might guess, is centered on the biopsychosocial model in medical education. So it gives me great pleasure to introduce today's presenter, Dr. Benzi Kluger. He'll share his presentation today entitled On Souls, Service, and Society, Extending the Biopsychosocial Model to Fully Support People Living with Life-Limiting Illnesses. Dr. Kluger is the Julius, Helen, and Robert Fine Distinguished Professor of Neurology and the Director of the Palliative Care Research Center at the University of Rochester. He's an internationally recognized leader in the emerging field of neuropalliative care and the founding president of the International Neuropalliative Care Society, an organization dedicated to improving care for persons living with neurologic illness and their families. In this talk today, Dr. Kluger will draw upon his experiences working with patients and families affected by neurologic illness. At the center of this model, he seeks to answer the questions, who is the person in front of me, and what parts of them exist beyond the reach of illness? Please welcome Dr. Benzi Kluger. Thanks. I think we're at the right height.
All right. Yeah, I think we're good. All right. People can hear in the back. Okay. Well, thanks for having me. So we're going to talk about some things that we don't always talk about in medical circles, things like love and joy and souls. Hopefully you'll be able to stay with me with that. And I'm going to kind of braid through my own personal journey in medicine and working with people with serious illness, along with my professional work as a clinician and as a researcher, and also some reflections about what all of this means for medical education and how do we train people who can be leaders and can really embody the biopsychosocial model. So to start with, I think we want to recognize the biopsychosocial aspiration as something separate than the model. So we could argue whether it's a good model, whether it's a complete model, but I think what George Engel named, namely that the biomedical model is too limited and that we need to get outside of the biomedical model if we're going to take care of people fully, is something that I think everybody can agree with. And although I was not an alumni here, I could have been. My dad, Jules Kluger, was a child psychiatrist and actually interviewed in 1973 to be chief of child psychiatry here. And I did a little bit more digging of why he wanted to come out here, and I could see clearly why he did. At that time and in continuing, there was a lot of focus on family dynamics, on community therapy. A big thing that he was very interested in was milieu therapy, of how everything that's happening around a child with mental illness affects them and is part of either their healing process or their continuing illness. And so he was a great influence on me. He stayed in Denver because of family, but I think his heart was here. And my mom was a psychiatric social worker. She was involved in the war on poverty and is also part of, I think, my social mission. And so, definitely very much their children. And part of why I'm here is this milieu, this thing that's so unique about the University of Rochester. Bob Holloway and Rob Horowitz both talked to me at the first time I came out about how Rochester was different. And the big difference was that the biopsychosocial model is part of the DNA of this institution. And so this is a place where you could have a crazy idea like having a clinic where there's a chaplain and a social worker and a neuropalliative care doctor all helping a patient and a family make it through their journey. And I saw that this was really going to be fertile soil. And I also saw just how dedicated this institution is to teaching doctors and nurses and social workers and others the importance of communication. And that's really the heart of my work. It's a big part of George Engel's work. And so I'm really happy to be here. So this is George Engel's model, and just call it a few things, and I think probably most of the people in the room are aware of this. The first is that he recognized that for most illnesses, if we focus only on the bio part of that diagram, we're going to miss a lot of things. And for some illnesses, including mental illness, we're going to miss almost everything that's important. So first of all, he had to expand what we are looking at when we think about illness. The second thing that he brought that I think is very important is complexity, and the fact that psychological and sociological and biological things aren't just contributors, but they also interact with each other. And that if we're going to fully understand illness and if we're going to fully treat people, we have to understand those interactions. And the last thing he, I think, was a master at, from what I've heard, I've never got to work with him, is just the importance of communication skills and the importance of relationship as the heart of our work as healers. And this, I think, is less known outside of Rochester, but is a very important and I think a seminal contribution to his work as a doctor and in medical education. And yet, we're still living in a biomedical world. And I think even if you read George Engel's paper from 1977, he didn't have any illusions that this essay was going to change the world. And I don't know if he would be surprised about the world we're living in now. For my dad, before he died, he reflected that he was seeing the same kids in 1996 as he was in 1976. The only difference is that they were now on 15 different medications and they'd been through 15 different homes. And so we are in a more biomedical age. And I think the other part of that comment is that we're not doing a very good job with social determinants of health. So this is something that I think that George Engel opened the door to, but we, I don't think we've really delivered on it. And I wonder, in today's day and age, would George Engel have been able to get his essay published in the journal Science today? I'm not so sure, because I think, have moved in a biomedical direction. So the questions I put for myself, I put for all of us, is how can we actualize the promise of the biopsychosocial model in improving the lives of people with serious illness? So that includes medical illness, that includes serious mental illness. And how do we educate healthcare professionals to sustain and grow and lead these types of practices? In other words, how do we do good in the world? And how do we train the best healers for the world? And use the word "for" very intentionally, that we don't want to just train the best doctors in the world, we want to train the best doctors for the world. And it's a bit of a different emphasis. My answer, which I will kind of go through in detail here, is a different kind of model. So it's a different shape, it's concentric circles. And it's also very intentional that these are not scientific terms. I think one of the weaknesses potentially of the original biopsychosocial model is that it was too tightly tied to the values of science. And I think one of the things that we need to do is to create a bridge that we have a new model that's really founded in human values, on philosophy and ethics. And at the center of this, I'll talk to you about my ideas about the soul, but that we have an irreducible essence of a person, something that falls outside, I think, what we can measure with science. As we move out, we get into service that's motivated by tending to that soul. And then society in this model is not simply a cause of illness. Society is also something that's a target for healing. And as we think about the impact of society on our patients, we also have, I think, a unique responsibility and a unique opportunity to help society heal and to create a society that's more sustaining for people living with serious illness. So in this first chapter, and I promise I'll go through these relatively quickly. I've told him to have until about 8 p.m. That is to talk about to heal a person. And this comes from Daniel Somasi, who's done some amazing work, who's a family medicine doctor and an ordained, I'm trying to remember what order of monks he is with. But in any case, he's done some amazing work. And from his book, he has a quote: "To heal a person, you must first be a person." And that quote and idea, I think, is influential to me. And I think as we're talking and thinking about these things, that the biopsychosocial model is not something that just applies to patients and families. It's also something that applies to us, and it's something that applies to all of our learners. And I will start by admitting that I'm a recovering reductionist. My plan going into medical school, and actually coming out of medical school and going into neurology residency, was that I was going to understand the neurophysiology of free will to such a degree that we would be able to eliminate that illusion. That was my driving force in life, and I'm embarrassed to admit that I can't think of a more biomedical goal. And here I am talking about the soul today. So life definitely can change you. But part of the reason why I was on that road is, one, my dad died actually on the evening of when I got accepted to medical school. And I think that was telling in a way because that really shook me in terms of my faith in God and was part of my move towards science and reductionism and objectivism. A second thing is that entering medical school, the biomedical curriculum, this was 20 years ago, but I think this is still true, was very much alive and well. And the neuroscience courses and the neurology courses definitely spoke to the intellect in terms of neurologic disease. At the same time, when I was going to medical school, there was what I would call the soft curriculum. And these were courses on spirituality and communication. And at that time and where I was, they were taught awfully. And the message I came away with is that these are not very important things to me. These were not things that I saw practiced. If these were important, they would have the best teachers in the university teaching us about spiritual care and how to take a spiritual history. And then I think one of the biggest factors is what's been called the hidden curriculum. And this is going to be a theme that I'll come back to again, but I think the hidden curriculum is we're immersed in this culture. And this culture is still very much biomedical. What we value, what we treat, where we spend our time, where we put our biggest efforts. And so all of those things, I think, serve to reinforce this idea of reductionism. And yet, I'm here today, and part of that is that the tools of reductionism are not up for the task of engaging with suffering. When I was a resident, a fellow, and then particularly after I became an attending, I saw horrible suffering. I saw patients with Alzheimer's disease, with brain cancer, with ALS. And at that point in my career, the thrill of diagnosis was gone. It was no longer fun to make a diagnosis of ALS because I now knew what came after that. And these tools of reductionism didn't help. Maybe in 30 or 50 years, we'll have a cure for ALS. But for me in that moment, it was not particularly helpful. And so I was left really struggling of trying to figure out how can I deal with the suffering? How can I deal with death, with relentless decline of neurologic illnesses? And I had the good fortune, and will be again a reoccurring theme of serendipity, that I happened to be in the right place at the right time and find the right people. Most of the neurologists I talked to about these things told me that I needed to work on my emotional armor. We talked about professional distance, talked about there's going to be ups and downs, and there's going to be times where you're sad, and times where you're maybe numb at the best. But these people, Gene Kuttner, who is on your right, actually was born at Strong Hospital, is one of the leading neuropalliative care researchers and happened to be a mentor. When I told her about the things I was struggling with, she told me I should look into palliative care. And so I did a little bit of reading about that. I asked her if she knew anyone doing palliative care at that time for neurology, and she said, I think you found your career. Julie Carter, who is in the middle, was at Oregon Health and was probably the second person, I think, to start a Parkinson's palliative care clinic. I was the first, in part because of her advice, is she said, don't wait for a grant, don't wait for papers, just do it and you'll figure it out as you go. And then Janice Miyazaki was an early proponent of neuropalliative care who's really been a beacon of light for me and was one of my early mentors when there was really no one else around who wanted to mentor people in neuropalliative care. So with their encouragement became another chapter or perhaps even a lifelong wrestling match with suffering and with human suffering. And to put some of this into perspective, I want to tell you something that a lot of the medical community doesn't know, which is that Parkinson's disease sucks. This is a quote from Ben Petrick, who is a catcher for the Colorado Rockies. But if you read the last New England Journal of Medicine review on Parkinson's disease, there's a lot of things missing there. So we all know about motor symptoms. They, I think, understate a little bit about dementia, which can affect 75% of people with Parkinson's. 2/3 of people have pain. There's social isolation, depression, demoralization. People talk about the cosmetic effects of having Parkinson's disease. One of our patients described her Parkinson's as a flamboyant illness because her tremor and her dyskinesias seem to come out at the worst time. If people have drooling, if they're using a walker, again, there's this social stigma that comes with that. There's caregiver distress. There's a biomedical community that looks at Parkinson's as a success story. And in some ways, it is a biomedical success story. There was the discovery of dopamine, there's Cinemet, which was successful, there's deep brain stimulation, which was the first surgical intervention that does all these sexy things with electricity. And yet Parkinson's disease still sucks. And we don't talk about that enough. And in fact, people in the Parkinson's community oftentimes feel like they're failing when their progressive illness is progressing. On top of that, it's the 10th leading cause of death for older adults in the US. So it's clearly not a good disease to have. And this is the disease that I've been working with the most in palliative care. But I work with a lot of other horrible illnesses. I work with people with brain cancer. I work with people with Alzheimer's disease, with ALS, some of the most feared diagnoses in medicine. And when we think about these, why does no one in this room want one of those illnesses? It's because not just the physical, but it's because of the total pain or the total suffering of these neurologic illnesses. Dame Cicely Saunders, who is kind of like the George Engel of palliative care, framed things a different way, but it's the same idea, and she talked about total pain. But this is simply another way of talking about the biopsychosocial model, and that there are multiple dimensions of suffering associated with these neurologic illnesses, and it's only a very small part of them that we routinely address in our care. So we might take somebody with ALS, we might talk about their pain, we might talk about respiration. We're not talking a lot about grief, their anger and frustration, their loss of identity, feelings of hopelessness, which are greater for people with neurologic disorders. In fact, I've had a number of patients say, I wish I had cancer, because at least there would be some hope with that. So these are just devastating illnesses, a lot of loneliness, isolation, financial concerns, and how do we address these things? And so despite having some very nice career development plans, life had other ideas for me. And so I became, because I was listening to suffering and I was wrestling with suffering, got into palliative care and neurology. And through this paradigm shift, I think has really two components, and I think they're true for almost any part of medicine, not just neurology. One part of this is primary palliative care, which Tim Quell also called generalist palliative care. We might call it the biopsychosocial model of care, but how do we do full person care for everybody from the time of diagnosis onwards? And then the second part of this is how do we integrate specialist palliative care, including hospice, including getting people to see chaplains and mental health specialists and other people for when these illnesses are getting really tough and really challenging. Again, this could be Parkinson's, could be almost any illness, but our current model is that we have neurologists or other subspecialists who are focused in on motor symptoms, Parkinson's medications. We have primary care doctors who are doing other medical tasks. Nobody is looking out for the caregiver. Nobody is really looking out to the patient as far as these other essential tasks that they need to do in order to minimize suffering. And so we have this state of affairs where if you're seeing a neurologist, you might have good motor symptom control. You have a 50-50 chance of having your depression treated. And then for advanced care planning, end-of-life care, caregiver support, almost all of those things are unmet. And in fact, people with Parkinson's are more likely to die in a hospital than they are at home, in part because of the job that we're failing to do in terms of preparing them for their future. And our hypothesis, and this has been a central thing over over a decade, is that if we brought in an interdisciplinary palliative care team, including a physician, nurse, social worker, and chaplain, that we could do better. And in fact, that's what we've shown. So this was a large randomized control trial, and I want to call to attention to the fact that our control group were people with Parkinson's who were being seen at UCSF, at the University of Colorado, at the University of Alberta, people who had access to social workers and chaplains but did not have this palliative care framework. What we showed was that people getting this integrated palliative care had better quality of life, they had better symptom control, they had less grief, their caregivers had less burden, reported a greater sense of peace, less anxiety. So it was clear to us that this model of care works. And an unsung hero along this journey is patients and families who I cared for. So this is kind of a modification of a quote, but listen to the patient, they will teach you how to be a better doctor. Kirk Hall, who is the gentleman here to your right, or to my right, is a gentleman with Parkinson's disease. He invited me to his support group in 2011 to talk about death with dignity and to share with me some of his concerns about fear of dementia actually being greater than the fear of death. And so it was eye-opening to me. I would also say, and we'll come back to this, that medical aid in dying, the law was pushed forward by a person with Parkinson's disease in the state of Colorado. So really opening my eyes to issues. And then he's been on every study I've done since that time. He's been part of our Patient and Family Advisory Council. And there are papers that I know I wouldn't have written, and there are things I know I wouldn't have done as well without Kirk and Melina and other people on that council. This other couple of young women are Carissa and Juju, who were diagnosed with juvenile Huntington's disease at ages 9 and 11. And because Huntington's disease has anticipation, they were diagnosed actually just 6 months after their father was diagnosed. And their first symptoms were having problems in school, and it was thought it was because of their father's diagnosis, but gene testing showed that it was Huntington's disease. Juju, who was the younger, had horrible pain. I helped her with that. We got methadone on board. We got her on hospice. And her older sister, Carissa, was just an amazing person. She was the Huntington's Disease Society's Advocate of the Year, and taught me a lot about how to be a better doctor. And I can remember in particular, one of our visits where I was asking her about sleep. She said she had insomnia, and I asked her why, and she said she was afraid of dying in her sleep. And she had seen her sister die, she had seen her father die, she had seen many people in her community die. And it was just this light bulb moment for me. And I remember going to Gene Kuttner, I think the next day, and saying, this fear of death is a spiritual issue. Are there anybody who can help us deal with this? And they said, yeah, they're called chaplains. And it was like this, I made this connection that these spiritual courses never made for me. But Carissa has had a very lasting impact on how I am as a physician. And I would, again, I think better integration of lived experience experts can't be understated. And so moving on from suffering is what is the difference between living and surviving? And there is a difference, and I think that difference between living and surviving is joy. And joy can be a revolutionary act in the face of despair. So when the medical aid in dying law was passed into law in the state of Colorado, we made it a practice that anyone being seen at the University of Colorado with a neurologic illness who made a request, whether they were eligible or not, would see our neuropalliative care clinic. And one of those people was a woman with cortical basal degeneration. She was very much set on getting medical aid in dying that day and trying to move things forward as fast as possible. She met with everybody on our team, and by the end of our visit, she no longer wanted medical aid in dying, and it was a change that happened when our chaplain saw her. And the chaplain said, Ryan, who's an amazing chaplain, said, we had our typical conversation. I asked her some questions, including where she found joy. She said her family, and then I asked her, how much more time would you like to spend with your family? And she said a lot. And it was that moment in the conversation that really changed things. And it changed things for our team because we realized that we had to be more systematic about asking for opportunities for joy, because if we didn't, people were actually going to suffer and they would die faster. I would also call to your attention that the number one reason why people request medical aid in dying is not pain, it's not loss of independence, it's the loss of the ability to partake in joyful activities. And so whether we can maintain joy or not maintain joy makes a big difference for people. The second thing that really influenced me kind of down this path of joy was hearing from research participants that the surveys we give them depress them. And this, I would say, is not that far off from the typical survey that we ask people, how sad am I? How much pain do I have? Everything is measured, I would say, from 0 to -10. And the best that we can do is being not sad, which is sometimes an accomplishment. Some of us, if we're dealing with depression or pain, getting to 0 makes a big difference. But I would say few of us, even people with depression, wake up in the morning hoping to get to 0. People are waking up in the morning hoping to get to +10. And so again, this was very impactful for me to listen to that and think about how can we look at this differently. The World Health Organization actually recognizes that quality of life has 2 dimensions, both a positive and a negative one. And we're very much focused on the negative side of quality of life. And so based on, again, these serendipitous occasions, we began to be very systematic about looking for opportunities for joy in our clinic. And so if we think about somebody, say, with Alzheimer's disease or ALS, we could ask them, where do you find joy? Where do you look forward to? Tell me about your life before this illness, and see what we can do to eliminate regrets and make whatever time they have as impactful as possible. This can include very simple things like having more ice cream, having simple touch, enjoying a sunrise, spending more time with family. It's resulted actually in a woman with MS who had quadriplegia going skydiving. There is a patient who recently passed away with PSP who we would always talk because they modified their RV to allow her to continue to travel, and so they would be going down Route 66 when they were having their visit with me. So this has become actually a tool. I gave a talk to the American Academy of Neurology talking about joy as a weapon to steal victories away from incurable illnesses. So there's a huge amount of power here. And I'd also say that there's room for joy in medicine. In fact, I would say there's more than room for joy, that joy is essential in medicine. During COVID, the number of tweets, the number of articles around joy markedly increased. There's been shown with research. And so I think we all know instinctively during tough times that we turn to joy. When we're not wearing our white coat and a family member or somebody else has had a bad day or a serious illness, we'll watch a comedy with them. We'll do something to try to lighten their mood. And so we absolutely need to do this, and not just with patients and families, but also with our teams. Can we create cultures of joy? And it's ironic, but I think people coming to our neuropalliative care clinic would be surprised at how much laughter there is, both within clinic rooms, but also outside of it. So as we get into joy, we're starting to expand the target of care, and we're getting into person-centered care, and this is where I'm talking about the soul being the center. But when we start to talk about joy, we're moving away from the idea of the patient. So a patient is somebody who literally, the word means somebody who suffers. Somebody defined by their illness, and we're moving into territory where this person now has their own hopes, they have their joys, they have their strengths, they have things that they can teach us. I think a radical notion, but a fundamental notion to the work I'm doing is that illness does not fundamentally change what makes life satisfying. People with serious illness, like everybody else, need love, they need joy, they need purpose. And there are people who, through their illness, have actually found deeper satisfaction in life. Michael J. Fox is one of them, who credits Parkinson's disease for finding deeper purpose in his life. Linda Emanuel, who's written some amazing work on existential maturity, talks about how her own cancer was yet a blessing to her and helped her to reconnect with things that are most important. I know for myself, I've learned a ton about grace and strength and dignity and mercy through working with patients, and have much more gratitude for my life because of listening to them and coming in with an open heart. Neither precision physiology, which I think is a more accurate name for what's oftentimes called personalized medicine. There are no people in personalized medicine. It's all about genes and HLA types and things like that. Or the biopsychosocial complexity. So I think George Engel also maybe missed the mark there with thinking about biopsychosocial complexity. People are not just a collection of biopsychosocial parts. The essence of a person, I would say, is irreducible. This quote from Eugene Peterson: "People are not problems to be solved, they are mysteries to be explored." And that really gets close to this essence of what I mean by the soul. A question that I often ask people in my clinics: is there a part of you that this illness cannot touch? Is there a part of you that this illness cannot change? And we're getting towards the soul, and it could be spiritual. It could be for some people that they believe in ephemeral soul, but I think everybody knows and everybody sees that there's something unique about every one of us. And so part of this idea of talking about the soul as an embodied spirit is thinking about what are those things that will transcend illness, will even transcend death for this person's family, and how can we focus on that so that we can maintain it, that we can grow it, that we can use it as a center point for that person's dignity. This is a book that I would highly recommend to people. It's a very, very deep book on the blind spot, and talks about how science for a very long time has been doing what's called surreptitious substitutions, where they're taking abstract and mathematical concepts and substituting them for reality. Kierkegaard spoke about the same thing when he said that truth is subjective. But an example from this book is temperature. So going back 1,000 years, we all know temperature is hot and cold. Scientists worked to look at temperature and found that it's correlated with molecules going at different speeds. And now we think that molecules going at different speeds is temperature, and that our experience of hot and cold is merely subjective. So we've totally flipped reality, and we've placed a higher value on these abstract and mathematical concepts. And the danger here is that science also comes with its own metaphysics. And if we are not paying attention to this, if we don't have the soul and subjectivity and human values at the center, it becomes very easy for the metaphysics of materialism to dictate what we're doing. And so that brings us to this idea of the embodied spirit or soul, and it brings us outside of the safety, outside of the sterility, outside of sometimes the illusion of control that we have in science, and it brings us intentionally into the messy center of healing, where there's a lot of uncertainty, there's a lot of emotion, there's a lot of things that are unexpected. And the lesson here from this work is physician, heal thyself. And for myself, That's been Zen Buddhism, but also over time it's been learning from people from all different religious traditions, Christianity, Judaism, Hinduism, Islam, about how spiritual traditions are dealing with suffering. Interestingly, if we think about the origins of medicine are spiritual. The work of shamans was to help people reconnect to the transcendent and the sacred and find their power in themselves. That's the origin. It's really just the last 100 years, which is an exception, that spirituality and medicine have been so separate. And so for myself, I know my ability to ask questions, I know my ability to create a safe space for people to talk about certain things absolutely came from this work that I have done for myself and with myself. So when we were able to see the spirit, I think, and I think others in this room might agree, that when we really have that experience of being soul to soul with another person, that love is automatic and our desire to serve is automatic. Caring is more than the proficient application of communication skills. And so I think it's important and it's critical that we teach our learners communication skills. But I think it's an error to think that that's all that people need to do. Having had a son with asthma, having been in the intensive care unit with my son twice, I can tell you that communication skills were great, but it was even more important that we had a nurse who really saw and heard us. And Bob Gramling has done some great work on feeling seen and heard as a measure of the quality of our care. But I think we need whether we call it unconditional positive regard, which was the term Carl Rogers used when he talked about humanistic psychology, whether we call it love, whether we call it caring, which is coming from the great work of Jean Watson, who is an amazing nurse theorist. And I think we actually have a lot that we can learn from the field of nursing when it comes to caring, is that we have to go beyond just communication skills. This picture comes from the Hospice of the Valley, who has an amazing dementia program. And I was talking to my friend Laura Hansen about their hospice program. And one of the things they teach their volunteers and they teach their staff is that when people lose the language of words, you have to speak to them with the language of love. And I just thought it was such a profound example of really embodying caring and integrating it into the work that we do. How we see the person in front of us absolutely determines how we care for them. And if we see the person in front of us as a problem or a problem list, that's definitely going to change the way that we relate to them. It's going to change the way that we are able or not able to find solutions together. This person in front of us is not reducible, they're not comprehensible, but they're embraceable. And if we are able to work together with that other individual, if we can find what Ron Epstein calls shared mind or dialogue, we're able to do so much. And the other thing that comes from this is that you as a healthcare provider are able to receive gifts that you would otherwise miss in terms of the strength and grace and humor of the people that you're seeing. Again, going to different religious traditions, this is Thich Nhat Hanh, who's been a very influential person to me in terms of how I think about compassion, but there are many things in other spiritual traditions that talk about suffering and why you're here from you. I'm not going to read a full quote that I'd written out from his work, but just to say at the heart of it is that you have to be fully present with the person in front of you. And if you're able to get to that point of being fully present, of being fully attentive, miraculous things can happen. And if you're not only is there a missed opportunity for connection, but you're going to be a less effective physician. I asked this question, not facetiously, is there room for love in healthcare? That I think we do treat love in healthcare as a four-letter word. I actually just submitted a grant to the Templeton Foundation. We'll see what happens to study love. But I would say informally, talking to people, some of whom are in this room about love, is that a lot of physicians, nurses, and other people use the word love when they talk about how they care for patients. And they also share that they're embarrassed to talk about love outside of those connections. And I would just put forward what would the world look like if we were able to talk about love openly and honestly in the medical curriculum. Last theme in this section that I think is very important, it connects to love, it also connects to safety. I think since being at the University of Rochester, possibly because of COVID, possibly because of other events in the world, I've increasingly been aware of trauma as part of serious illness. And serious illnesses themselves are traumatic. Being a caregiver, seeing somebody change in front of you and being helpless and hopeless to do anything is traumatic. And our healthcare system is often traumatic. two examples of this. One, there was a great article in the New York Times about medical gaslighting, but this happens all the time. It happens more often for women. It happens more often from people from underserved groups, of people who are not having their story listened to, or being told that your pain is not from X, Y, or Z, who are being told that you don't need medicine. The other thing that I'm seeing also is working with people from inner city Rochester. Charles White, who actually works with us, he is a lived experience expert and a community advocate, talks about how he was treated as a criminal for being a Black man with MS. And the stories of how he was treated in the emergency department and elsewhere as he tried to get this diagnosis are really horrifying. And so I would just put that out there, that we need to be conscious of this, and we need to think about how can we create healing spaces as opposed to traumatic spaces. And so the fifth lesson here is just how important it is to make time to be present. Saran Epstein, who some of you may know, wrote a wonderful book on attending, about mindfulness in medicine and finding shared mind. The way myself and our group has manifest this is that every afternoon before seeing our patients, we will have a silent meditation, and then we will set an intention for the day. And that intention might be to be present, that intention might be joy, it might be love, it might be curiosity. But it's important for us to be able to break away from all of the stuff of our world and RVUs and emails and things like that, so that we could be fully present with the person in front of us. The first times we did this with my University of Colorado neuropalliative care family, things felt great. And then the first time we had residents and fellows joining us, I felt nervous. And I felt that I was going to come across as an even weirder person than I actually am. But fortunately, and I would say almost without exception, our residents and fellows and medical students relished that time. And they felt seen and heard, and they felt, I think, connected to patients also in the afternoon in a way that they didn't always get, that part of them wasn't nourished. And so I would say that our learners definitely have a hunger for doing these soft skills if they're done in a way that's heartfelt and that's meaningful. So moving on then, we are here to serve, and there's various ways that we talk about, but I think it's important that we also ask the question of who do we serve? And this is a quote, if people haven't seen the Kenyan commencement speech by David Foster Wallace, This is Water, I would highly recommend it. It's just a magnificent speech, but he talks about, I think one of the most important ideas there is that we are all existing in water. So the analogy there is that there are fish who are in water and they don't see the water that they're swimming in. The same thing is true for us in culture. We don't see the culture that we're living in. And the most important kind of freedom, the one that's most precious, is the one about choosing your values, choosing your culture, and not falling into the winning and achieving and displaying. The other quote from that speech that I really like is that not worshiping is not an option. Everybody worships. The only choice you have is what. And this is a slide taken from Ray Dorsey wrote a beautiful article on the McDonaldization of medicine. And I think the title says quite a lot. And we definitely are seeing more McDonaldization of medicine now, even than I think at the time of this article. But are these the real goals of medicine? Is our goal to be efficient? Is our goal to do things that are calculable, predictable, highly controllable? And in medicine, he gives examples of billing codes and faster clinics and big med rankings and things like that. But is that our goals? And I would ask that both for us personally, because we have the opportunity with every person we see to break that mold. And we have the opportunity with every person we see to come in there as a person and help the person in front of us. And I would also say that we are all social beings, we're all political beings. And so we have the opportunity in terms of what we support or what we fight against to change this system. It's important that we think about creating services and not division. So I'm glad with the introduction, it was introduced as the service of neuropalliative care. And that's something that I think about quite a lot. But part of the idea of services and not divisions is that my goal is that every person with a neurologic illness seen at the University of Rochester gets neuropalliative care. My goal is not that everybody sees me or our team. And part of how we do that is we make social workers and chaplains more available. If we were a division, we would have a hard time, as does everyone else, justifying 0.2 FTE of a social worker. If we're speaking for the whole department, we have a much easier time getting 1 to 2 social workers. Same thing with chaplains. So we need to think about how we work together and how can we be bridge builders rather than gatekeepers for the services and the specialties that we provide. Gene Kuttner again comes up here about practicing palliative care in your colleagues and administrators, but I remember talking to her about working out some issues with my chairman, and as we were talking, I said, wait a second, you're palliative care on this person, and she said, yeah, that's right. I'm practicing palliative care. I do it all the time with everybody. And so it's been important, to me, this quote from Abraham Lincoln, I don't like that man, I must get to know him better. But a lot of people see administrators as adversaries rather than as colleagues. And it's true that, administrators may have other pressures for RVUs and things like that, but it's also true that most administrators are in healthcare for a reason. They have backgrounds as nurses, as social workers, and most of them care about the same things you care about. And so if you're able to embrace them as colleagues, you can really build great things together. And I would say, and we'll come back to this idea again, is that it's important that we teach our students how to get things done in the world, how to make connections, how to work with other people, because far too often, I think physicians find themselves in a position where they see themselves surrounded by adversaries and nobody cares about the things they do, but they haven't been presented with the skills to change that. So to know and not to know and not do is not to know. And this is a quote that's been attributed to numerous people. But the fundamental idea is the same, is that it's important if you have knowledge and that you're not changing things in the world, you don't have knowledge. And I would even extend that, that for us, if we know and we're not doing things for everybody, perhaps we don't know. So part of my scientific background is I'm involved with implementation science. And implementation science is recognizing that it takes 20 years to go from drug discovery to a randomized controlled trial, but it can take an additional 20 years to go from that randomized controlled trial to people using that medication. And it's both during the first 20 years, but also during the second 20 years that people are suffering because of lack of access to medications, because of lack of clinic standards. And you could multiply that by 10 when you think about behavioral interventions. When you think about mental health in this country, when you think about palliative care, there's a huge implementation gap. We've known for over 10 years that early palliative care not only improves quality of life for people with cancer, but it actually extends life. That people getting early palliative care on average live about 3 months longer. If it was a pill, I think everyone would be prescribing it. But because of this implementation gap, people across the country are suffering for lack of palliative care. So this is something that I think about a lot, and also per this image, that us in academics have to think about how we get care to people in the community. And I think we're in a privileged position and we may not think about this, but if we're not thinking about it, then we are contributing to the problem. So the first part of this work came for me actually from an NIH reviewer comment who liked my grant, okay, I gave it a good score, said this was going to build our ivory tower an extra 10 floors and it would be great, but how is my work helping people in the community? And it emphasizes that the majority of people in this country get their care outside of academic centers. And so that was another wake-up moment for me. And so we published this study earlier this year. I think it's just version 1.0. There's a lot more work to do, but we showed that teaching neurologists in the community basic palliative care skills and then providing them with telehealth support, this was actually long before COVID when we started this trial, but providing virtual house calls with chaplain, pharmacists, and other members of a team, improved outcomes for people in rural Colorado and Wyoming and California. Importantly, too, we improved the lives of the clinicians who were part of this project. And this was a very moving quote from one of our neurologists who said, the greatest part of the study for me was feeling less alone and caring. And I think this quote speaks to two things. One is that I think we all in this room know that we have to work against the healthcare system to care for people a lot of times. That's part of the loneliness. And the second part of the loneliness goes back to this idea of we're not seeing the water. That people feel alone and isolated, particularly in private practice, but even in academics, as they're working upstream to take the best care possible of the person in front of them. And this gets back into human values. And this is not something that's isolated to community neurologists. This was a large PCORI-funded study that involved 34 academic centers across the country, caring for over 100,000 people with Parkinson's. And the goal of the study, which we just finished, was to make integrated palliative care a new standard of care. And we've actually moved the needle quite a bit. Sanjay Seshadri, who's here, was our project manager and has done an immense amount of work to make this happen. But we actually did start to change physician behavior. We actually did start to do these things. But we only did it, again, because we listened to the people that we were trying to teach. And when we came into the study, I had the naive notion that we would just have 10 modules on palliative care skills. People would watch the modules and then they would become, quote, great doctors. But what we heard was that, yes, we need that information, but we also need systems and institutions that support us in this work. We need to be able to have MAs have the control to give out scales. We need to be able to pay social workers and chaplains. We need to be able to build bridges across divisions. Some of the things that we do well at Rochester were some of the lessons from this. And this quote, "You do not rise to the level of your goals, you fall to the level of your systems," I think was really hammered home to me through this project. And as a result of it, we actually created an additional 5 modules, one on philanthropy, one on how to work with administrators, one on how to create business cases, one on how to create bridges across divisions, that really talked about some of the nuts and bolts about how do you make system change. And if nothing else, I think this project, which was successful in many ways, one of the things that I think is also a success is going to be documenting the system barriers and the institutional barriers to this model of care. So going back to even our first slide, why is the biopsychosocial model of care not happening? We need to think about systems. So this is a plug for making systems thinking it's an essential skill for doing good, but I think it's an essential skill for people in the healthcare professions. I was really turned on to this by Stan Dempsey, who was a philanthropist who I worked with, who used this in business. But from the get-go, how I started the first clinic of neuropalliative care in the country, advice there being is ask for forgiveness, not permission. But then moving forward to other things, it's all about systems. It's all about how do you do good things in the world? How do you get people to collaborate? How do you get administrators and chairmen and chiefs and deans to do things that you think are important? How do you share your vision? So I think this is really an essential skill as we're trying to get the biopsychosocial model to be something in the world more than just an aspiration. So to close is the idea of the healing society. And the idea here is that we don't want to look at society just as a source of illness, but as a target for healing. And we all have, I think, a unique knowledge and a unique position. Physicians are still trusted, nurses are still trusted, and so we have an opportunity to create a better society through our work. From Buddhism, there's this idea of Kuan Yin, who has 10,000 arms and 10,000 eyes. And the idea here is that we become a society of compassion when everybody recognizes that they are Kuan Yin's hands and Kuan Yin's eyes, that we are all the goddess of compassion. When I teach people research, and this has been definitely part of my work, this might seem sacrilegious, but I would say that research cannot and should not limit itself to scientific questions. That we have to consider the cultural and political and societal goals of our work. To give a couple examples, published a paper about 5 years ago now on the palliative care needs of people with Parkinson's, and part of that paper was that we had a control group of people with metastatic cancer. And we showed in that paper that people with Parkinson's had an equal level of need of people with metastatic cancer. It wasn't so much a scientific question as a political move. And the political move is that if we're giving palliative care to people with metastatic cancer, we should also be doing it for Parkinson's disease. I wish I was, and hopefully in the future will be more sophisticated. Am I failing to collect outcome measures that are important to policymakers? Am I doing things where I am shooting myself in the foot because I'm not telling the right story? And so it's, again, going with this theme of getting more people in the room in order to move things forward faster. If we're not considering equity in care, we're contributing to inequities. And this was really hammered home to me. I was part of a workforce on serious illness research for the National Academies of Science, Engineering, and Medicine. And there were several talks. If we think about this implementation gap for behavioral science, we do a behavioral science study. There's a randomized controlled trial. It takes 10 to 20 years to get it into academic centers. And then maybe then we'll start looking about how do we get this to Black people in inner city communities. And so how are we going to do things where we're thinking about equity immediately and from day one? And I would also say, just the events over the 4 years, as I'm sure with others in the rooms, have just made me much more aware of the forces of racism and everybody's obligation to practice anti-racism in terms of getting equitable care to people who need it. People spend less than 1% of their lives in clinics, and yet that's where we spend the vast majority of our efforts. There's a compassionate city model Alan Kelly here has put forth about how do we get a whole community behind serious illness care. There's also the dementia-friendly communities movement, where we can have movie nights or movie days where people with dementia feel welcome. We can have dementia cafes. How do we get people across the board involved? Again, to call out Sanjay Seshadri, bridging both of these things, just got one of the O'Hare grants to look at Congregational Connect for people living with dementia in inner city Rochester. And that program is how do we get volunteers from churches, from synagogues, and from mosques to be able to support people living with dementia to get to their appointments on time, to find care. And it's been a beautiful program. It's actually been very successful at Indiana and Memphis. So I think a lot of more that we can do here, and the undercutting and cross-cutting theme is that if we want to move towards a healing and a healthy society, we have to have a much broader community, and I'm purposely using this word of activists. And that includes not just doctors and physicians, but sociologists, anthropologists, philosophers, ethicists, people living with illness. We have some great resources in our community. Phyllis Jackson, who leads the Interdenominational Health Ministry, has done some amazing community work. And we're missing out if we're not partnering with all these people. Again, if our broader goal is that we want to do the most good in the world possible. And so this brings us to the end of the talk, Meliora, Ever Better. And I think some of our work here is advancing the biopsychosocial model, that the biopsychosocial model is not something that was set in stone in 1977. Ideally, it's a living, breathing document, and it's going to change over time. This is my vision for how I think the biopsychosocial model might be more effective, that we have humanism at the center, that we have society at the periphery, but other people may have other ideas. But I think we need to continue to work on this if we're going to have it see greater influence. The provost, who is now in the process of leaving, created the transdisciplinary research grant, and I'm working on one with Kathy Hefner from the School of Nursing to create a transdisciplinary research center around biopsychosocial model. But the idea here, again, is that we want to go beyond multiple disciplines, even interdisciplines, to create new disciplines, to create disciplines that are centered around novel models of care. And University of Rochester, I think, is one of the few places in the country, perhaps the world, where this type of thing is possible, where there's this biopsychosocial model in the DNA, and where there's this idea of working together across silos. Pioneering new models of care. This is a big part of what attracted me to come to the University of Rochester, was hearing about, for example, the geriatric orthopedic clinic, where we have geriatricians working with older adults and orthopedic surgeons to make the best decisions possible for older adults. Tom Caprio and others have been doing some great work with ECHO to get better care into nursing homes for people with dementia. I think our clinic in neuropalliative care is also an exemplar of this kind of biopsychosocially informed care. There's other things happening in family medicine, but I think we need to keep doing this work to show the world what's possible when we're able to break down barriers. And again, to circle back to this idea that we don't just teach, we also learn from the people we teach. And I have been immensely inspired. I'm coming in today actually with a great amount of hope for the future because of my work with medical students, nursing students, and others at our recent International Neuropalliative Care Society. The majority of people there were fellows and students and residents. And I think this generation of people gets things at a different level than prior generations. They really care about person-centered care. They've lived through a pandemic. They're looking forward to a world where our environment may collapse. And I think, again, having dialogue with students is going to lead us to new and better places. So to summarize, I think the core lessons is that we have to pull in values from outside of science. We have to bring together transdisciplinary teams. We have to practice systems thinking. And we have to intentionally, not accidentally, intentionally support the heart, mind, and soul of our future leaders and healers. And so with that, I'll open things up to people's thoughts and responses and questions. And if you have questions, use the microphone because it's being recorded.
I have a couple of questions. One's more medical and one's more personal. So I'm a family doc. Has there been anything about continuity in terms of conveying to a patient or a family this caring and love? Like this nurse in critical care was able to show your son that she really cared and loved, in an hour. Whereas I, see people for 15 years. Mm-hmm. Does it make any difference if when they start to get critically ill or die that they know me and I know that? Does that, or if they see you as a consultant versus me?
Yeah, I think it does. It matters a lot. The term that comes to mind and something that we talk about in our clinic and models is non-abandonment. And I don't know if I shared this, but there's a quote in neurology that neurology patients don't die, they just stop showing up to clinic. And I think part of that is that we're not providing valuable services throughout their journey. And for people who transfer their care to our clinic, there's a sense of loss because the person who's been with them for the last 10 to 12 years is no longer with them and by their side. And so I think, you could have intense caring in a moment, but you also can have very intense caring over time. And I think they're both really valuable.
And the second question is, sorry. So if I care for my patients and I don't have a group, how am I okay? I mean, they suffer, they die. I'm sorry.
No, if I'm hearing your question, and you may have heard this before too, is number one is, and this gets back to that continuity of just how valuable it is to have somebody on the journey with you. And even if that journey is not perfect, even if you don't have all the resources that you would want or need, I can say, and I could tell by your emotionality about this, that your patients love you and you love them, and that means a lot. And at the same time, we can work for these things, we can do community-based care, we can work at new models, and that's equally important. But I would say, that love, seeing that person in front of you is really the center of it. So, and thank you for all the service that you've provided to your patients.
Hi, I'm Leslie Malo, and I'm a retired pediatric surgeon, and I had to start the surgical program at Marybridge Children's Hospital. And met some of the same things. I wish I had that Abraham Lincoln quote to begin with, but I didn't at the time. There was one thing that, and this is both as a patient. When I was in medical school, I had a very severe mountain climbing accident with a severe craniofacial injury and was in a coma for a month. And so I really remember going back to school. And then what struck me the most during that period of time, in and out of consciousness and in a lot of pain, was some people touched you differently. There were nurses that honestly, if I could have gotten out, I would have strangled them. And others had a different touch. You felt it, and you felt the care when they touched. And it's sort of like when your mom takes your temperature when you're young, and her hand feels so good, and because you're not feeling well. I think I had a resident who had on his Mormon missions, had taken care of like 90 patients at a time. And I said, well, how do you do that? And he said, you take their pulse. And it provides touch. It provides information. You know whether they're going to die in a minute. And I don't think that we're emphasizing that anymore in every exam. And now I have a neurologic disease, and I was afraid to go to my doctor because I had hands and feet things, and I was fatigued, and he kept telling me I was depressed. And I said, I wake up wonderful. And it was about 10 years. So it was very, very frustrating. And I loved your point about listening to the patients. But are we teaching our students now that how you touch somebody when you're doing the exam is going to make a huge difference? I think they ought to have a whole course on that, besides the open-ended interview.
Yeah, I can't speak to what's happening here and now. Maybe somebody else could. I definitely was not I never got that as a medical student myself. Actually, the last conference I spoke at, I had a slide about embodied care. It's something where I think actually we can learn a lot from nursing, where they do talk about caring and embodied care and spend time separating caring from other tasks. Yep. Yep. And I think it also gets to, I didn't emphasize this either, but all of our teaching is happening like at this level from the head up. And so whether you have a lived experience or whether you have a unique teacher or unique, a lot of this stuff happens accidentally. But there certainly are ways that we could be purposeful about helping people to get into their bodies, about having people to have that lived experience, to feel what it's like to be on the other side of the examining table. Right. I totally agree. Question here?
Your talk was organized in chapters. Do you have a book?
I don't.
I
Maybe
would
at
love
some point.
this. I would love this.
Yeah, it seemed to be, I spent a lot of time thinking about this over the last 2 months, and it seemed to be the most elegant way to bring together an enormous hairball and make it somewhat organized.
I want to thank you very much for your presentation. I worked for 30 years as a hospital chaplain. Interestingly, it was a physician who taught me one of my most important lessons. I was covering a NICU at the time, and a baby was dying, and it was time to go to the back room with the family. And the parents had been getting endless mountains of information about their baby's condition, and you have to do this, and you have to do that, or we have to try this, or we have to try that. And it was futile. So this was the situation in which the parents went into the back room. And the physician that came in, who was overseeing the care, and sat down and sat silently for a few seconds. And then he said something that I never forgot. He said, you know, your baby's condition is so complex, so confusing. I don't know if I understand what's going on. What is your understanding of your baby's condition? And everything broke wide open, and the parents knew deep down exactly what was happening.
Mhm.
And that being said, I just want to emphasize the power of presence. You know, I think physicians think that they have to fix things. But that active, engaged listening, where you are there for the patient, and in that moment, that is what counts.
Yep.
And I think that presence is, and I could tell you many, many stories, but I'll leave it at that. The power of presence in which a person empties his or herself out to allow the reality of the person in front of them to be spoken aloud.
Thanks for sharing, and also, brings up the value of silence, which again is something that we're not really taught, but is incredibly valuable, and also the value of a beautiful question, to be able to turn something. So thanks for sharing that.
Well, thank you, Benzi. That was a really fantastic talk, and I learned a lot from it, so thank you.